Hey everyone, welcome. This is Miss Nicole Sheridan with Georgia Northwestern Technical College, and I'm located on the Floyd County campus. I'm going to be doing your lectures for your Fundamentals Unit 2. And the first chapter we are going to start is one of the most important ones we're going to cover in this whole course, and that is the basis of nursing, what all nurses do. We follow the nursing process. So chapter 4 is all about the nursing process, critical thinking, and decision making. So it can feel confusing to be asked to come prepared to care for a patient you may know nothing about. Yet every day, nurses care for patients who are newly admitted to the nursing unit. The nurse knows nothing about the patient other than perhaps a working medical diagnosis, yet he or she must find out the pertinent or important information about the patient and develop an appropriate plan of care in an hour or less. So in this chapter, you are going to learn the steps of the nursing process, and this is our decision-making framework, and it's used by all nurses to determine the needs of their patients. And it helps us decide how to best care for them and also how to best meet the patient's individual needs. Tailor their care to best meet the needs of your patient. You are going to learn how to obtain pertinent information from various sources so that you can make those correct, best decisions about your patient's care. You're also going to learn how to organize that information into what's called a care plan. And a care plan is a documented plan for giving patient care. And it includes physician orders, nursing diagnoses, and nursing orders. So that care plan is super important because other nurses should be able to pick up that plan and be able to follow it. It needs to be both consistent and appropriate during the hospital stay. And it needs to adapt based on your patient's needs. So we are going to cover all that in this chapter. We are going to start here with decision making in nursing and discuss critical thinking. So one way nurses make such decisions is by the use of critical thinking. So there's many definitions that exist for this term of critical thinking. But to keep it simple and clear, critical thinking is using skillful reasoning and logical thought to determine the merits of a belief or an action. To think critically, you must think about how you think so that you can improve your ability to make sound decisions about your patients and their care. Nurses who use critical thinking avoid jumping to conclusions about patients or patient care. They also avoid making decisions based on assumptions. Never assume. They validate or ensure the correctness of the information that they are obtaining. So it's sometimes very tempting to simply, quote unquote, do what you're told or just follow orders, rather than to think critically about your nursing practice. However, but you must learn to think purposefully, using reasoning and logical thought to determine whether your actions are appropriate for the optimal care of your patient. The following example depicts a nurse who uses critical thinking when caring for her patients. So a nurse receives an order from the healthcare provider for an antibiotic to be administered intravenously, IV, to a patient who has developed pneumonia. The nurse remembers that a patient has an allergy to another medication in the same family of antibiotics and validates that memory by checking the patient's allergies in the chart. So she remembers that the patient was allergic to an antibiotic in that same antibiotic family, and she validates that. She double checks it in the chart. The nurse further validates the information by asking the patient to relate, again, the name of the medication and the type of reaction that occurred in a previous hospitalization. So ensuring that is entered into the chart. The nurse then notifies that healthcare provider of the potential for the patient to have a reaction to that ordered antibiotic. So she is critically thinking about that order. Just because that order came from the doctor doesn't mean the nurse should just go with it without thinking about it. You have to critically think about every single order. Is this appropriate and safe for my patient? The thinking nurse is not working on an automatic pilot, not simply carrying out the healthcare provider's orders. The nurse has prioritized the patient's health and well-being and has prevented a potentially severe medication reaction here. So you are going to use critical thinking skills many, many times during a shift when you work as a nurse. Your job now is to learn to think in a way that perhaps is different than you are typically accustomed to. So you're going to practice that critical thinking at every opportunity. And that's all what nursing school is about. We are here to help you develop those essential critical thinking skills. In addition to learning to think critically, you must learn to make nursing decisions using a framework for decision making, and that is known as the nursing process, which we will be covering in this chapter. So critical thinking is the ability to recognize problems and raise questions when necessary, gather evidence to support answers and solutions, evaluate potential alternative solutions, and it also is about communicating effectively with others to implement solutions for the best possible outcomes for your patients. So without even being aware of it, half of the time, nurses critically think their way through every single day. The thinking process that guides nursing practice must be organized, purposeful, and disciplined, because nursing decisions often profoundly affect their patients' lives. And that organization I'm talking about is that nursing process that we are going to be discussing in this chapter. So I have one example for you of a patient scenario. So I once had a patient that was scheduled to go get a pacemaker at 9 in the morning, and the physician wanted the patient to get 2 units of blood before going downstairs to have the procedure done. So I administered the packed red blood cells per protocol, and then about 30 minutes or so after that second unit of blood got started, I started noticing that his oxygen saturation went from 95% down to 92%, and then down to 90%. It was kind of trending downwards. So I put on 2 liters of O2 on him, and it came up to 91%. You know, it just sort of hung around there in the low 90s on oxygen. So I stopped to myself. You know, I used my critical thinking skills, and I thought, what is going on here? So then I look at his medical history in the patient's chart, and I notice congestive heart failure, or CHF. Then I look at his intake and output in the chart, and he was what's called positive 1.5 liters, So he was positive 1.5 liters, meaning the patient is retaining 1.5 liters of fluid in his body. So there I go. I think about like a liter of Coke, you know. So he has a whole liter of Coke and then another half in his body, just to make it visual. So he is retaining 1.5 liters of fluid in his body. And I thought about how he got the extra fluid in general. And because of his congestive heart failure, he can't really pump out the fluid he already has, let alone any additional fluid. And I thought, I just gave all those packed red blood cells. That's adding fluid to his body. Maybe I should listen to his lung sounds. So his lungs were clear earlier, but now I heard crackles throughout both lungs. So I think, okay, he's got extra fluid that he can't get out of his body. So what do I know that will get rid of extra fluid and make him urinate? Maybe some Lasix? So I ran over my thought process with a coworker before calling the doctor. And they agree with me. Lasix sounds good. So I call the doctor, and they say before I could suggest anything, the doctor says, give him 20 milligrams of IV Lasix times one time, and I'll put the order in. Click, they hang up the phone. So I give the Lasix per orders, and he proceeded to pee like a racehorse, lots of urination. But once he got that excess fluid off of his body, he was actually able to come off of his supplemental oxygen that I had put him on earlier. So he was actually able to come off of oxygen before he went down to get his pacemaker procedure. So learning how to critically think like that, it takes time. It's not something you just read in a textbook and you can just, immediately apply at the snap of your fingers. It takes practice. So this concept gets introduced to you during nursing school, and then you start to see it in action during clinicals. And at first, it'll be mechanical. You have to think to yourself, okay, I got to think about this particular situation or this doctor's order, whatever it might be. But eventually, you're not going to have to necessarily think about it. It's just going to be coming to you naturally. You're going to be critically thinking with the best of them. So we're going to start talking about the steps of the nursing process. Now, I want you to remember that the nursing process is a framework for decision making that nurses use. So by following these steps, nurses determine the actions to take. It kind of orders your steps in a way, and it determines the effectiveness of those actions. So an easy way to remember the first letter of each of the steps of the nursing process is to use the mnemonic ADPI. And you see you got a picture of a cherry pie here on the screen, and it stands for a delicious pie. So A stands for assessment, D diagnosis, P for planning, I intervention, and E for evaluation. The first step in the nursing process is assessment. So that is the gathering of information through signs and symptoms, patient history, and both subjective and objective findings. And we're going to talk about subjective and objective data here in just a minute. So just as a healthcare provider gathers information by performing a physical exam and taking a patient history, the nurse also collects information, gathers data about the patient through asking questions, like interviewing your patient, performing a head-to-toe assessment, and reviewing laboratory and diagnostic tests. So the assessment, first step of the nursing process, is all about gathering data about your patient. D for diagnosis is the second step of the nursing process. So during the diagnosis step, that is when we formulate a nursing diagnosis through analyzing the assessment information that we have gathered. So I take if we want to equate it to like baking a cupcake, right? and you're gathering all your ingredients, you might have a bunch of ingredients in your pantry that you might not need. You only need, like, the flour, the milk, the butter, the sugar, whatever you might need to bake the cupcake. So you need to, tailor that assessment data to fit your nursing diagnosis that you pick for your patient. So you kind of cluster the data based on what supports your nursing diagnosis. Like you're gathering evidence almost to go to court. You're gathering evidence to support your nursing diagnosis. Nursing diagnoses are related to the needs or problems a patient is experiencing. So these are completely different from a medical diagnosis, and they're selected based on definitions and defining characteristics. And so we're going to cover later in the slideshow the difference between medical and nursing diagnoses. So I'm going to put a pin in that for 1 second. And we're going to move on to step 3, planning. So planning step is the process of prioritizing and deciding what nursing actions should be performed to help resolve or manage each patient problem. In addition, the nurse determines the expected outcomes or the goals for the patient to meet for the nursing diagnosis to be resolved. They also set a realistic time frame that they want that goal to be met. The nurse then decides on an appropriate interventions to resolve each of the patient problems or nursing diagnoses. So the nurse is thinking, my goal is for my patient to walk to the bathroom. So what can I do as the nurse to get them up to the bathroom? What can I do to help my patient succeed? That is your implementation step. What actions do I need to take as their nurse to help them meet their goal and to help them improve? So the planning step is all about determining those short and long-term goals and determining the priorities of our care. The implementation step is the process of taking actions to resolve the patient's problems. So remember, the patient's problems are your nursing diagnoses, which we'll cover here later in this slideshow. So implementation is taking action, and those actions are called interventions. When the nurse performs those interventions, it's called implementation. The nurse implements the plan to help resolve the patient's problems and help them meet their goal. The evaluation step is the last step of the nursing process, and it is performed when the nurse reflects on the interventions that he or she has performed and decides if they have been effective or not. Have they brought our patient closer to achieving their goals or outcomes set in the planning step? If not, then we're going to need to revise this care plan. We're going to need to change maybe some of the interventions, or perhaps change some of the goals. Tweak it to better fit the needs of our patient so that they can be successful. You never want to set your patient up to fail. You want to pick goals that are very realistic and patient-centered, that are very measurable, and they have a defined time frame. We're going to talk about that more in detail, about goal setting, later on in the slideshow as well. We're just touching base on it right now. So although it does look like this nursing process is performed by a step-by-step sequence, flexibility is also important. It's often necessary to best meet the patient's needs. Being flexible Some of these steps may slightly overlap, and the nurse may move among the steps as he or she makes decisions about patient care. One of the figures in your book, figure 4.1 on page 47, gives you a good visual example of how the nursing process can overlap. So this picture in your textbook on page 47 shows the interconnected steps of the nursing process, and it shows how the nurse continuously uses this decision-making process of the nursing process. So once you get some experience and things won't feel so mechanical to you anymore, you're going to be constantly using your critical thinking skills, constantly using the nursing process, even without even really thinking about it. Like you could be like at Walmart or the grocery store and see another shopper, for instance. You know, you see their swollen ankles and such, and you're diagnosing them without even realizing it. So soon you're just going to be critically thinking with the best of them. And we like this meme here. It says, keep talking. I've already diagnosed you, and I have interventions and goals planned out for you. Step 1 of the nursing process is assessment. So this is where the nurse is collecting data. The information about the patient is gathered. The information should encompass the whole person. You know, it's not just the person's physical body, but also mental, like psychological, and spiritual aspects of the person, as well as taking into account their culture. So it needs to encompass the whole person. You're collecting all this information, and you're helping to identify areas that either could potentially be problematic or certain problems that are already occurring. The client's strengths are also identified here in the assessment part of the nursing process. And that's very important because your patient's strength can be supportive in changing problems and enhancing their quality of life for the patient. So as the nurse assesses the patient, critical thinking is used to determine the appropriate and relevant data. We are organizing the data, validating the data before we record and report the data. So there's 3 components to assessing patients, and the first one is interviewing. So when we are interviewing our patients, like on an admission assessment, for example, they just got to your nursing facility or your nursing unit in a hospital. So avoid simply asking the questions on a form and obtaining very minimal answers. Rather, you need to listen carefully to their answers and ask for clarification if needed. Ask for additional information as it's appropriate. So it requires you to think of and ask questions that may not appear on your nursing interview form. So there's many situations where the patients just may not want to volunteer that important information simply because they just don't recognize that it's important. So if that happens, you may find out very valuable facts that are very crucial to providing appropriate nursing care, you know, much later than you needed to know about them. So sometimes you may have, you know, the other end of the spectrum where patients want to give more detail than is necessary for you to obtain, you know, that important information that you need. For example, a patient may spend a great deal of time describing what was happening before he fell and injured his back, but you must listen carefully to extract what is important out of there. If the interview is taking an extended amount of time, It is appropriate to find a polite way to redirect the patient to the subject at hand. Some ways to do this include saying, "Can you tell me more about the pain you've been experiencing? Now, let's get back to what happened after you fell. After that happened, what did you do to relieve the pain?" So those are some polite ways that you could redirect your patient back to your initial question. So interviewing is one way to assess our patients. Another way is, of course, doing a head-to-toe physical assessment. So physical assessment usually is performed in a head-to-toe pattern just to avoid omitting any important data. Many hospital admission forms include a head-to-toe assessment guide for nurses to follow. However, you are responsible for obtaining thorough data, whether or not it is found on an assessment form. So you kind of have to get that process down, head-to-toe assessment, and everything to look out for. And that's in chapter 21 of your textbook if you'd like to review. So in general, on admission, the RN is responsible for performing a complete assessment when the patient is first admitted to a nursing unit in the hospital. The RN is going to establish the nursing diagnosis, help establish the goals for the patient during the hospital stay. However, in many settings, the LPN may do it all or part of the assessment, and then their assessment data is confirmed by the registered nurse. So always follow your facility policy and practice within the scope established by your state's Nurse Practice Act. Another technique for assessing patients is reviewing the results of their lab and diagnostic tests. So sometimes nurses think that analyzing lab and diagnostic test results is strictly in the realm of the physician. This couldn't be any farther from the truth, and it can be very dangerous. Although the physician and other healthcare providers will review the results of lab and diagnostic tests, it is important for nurses to examine them as well. As you learn more about the abnormal results of these tests, you're going to understand how they affect the patient's nursing care. For example, if you have a patient whose white blood cell count is very low, and we know those white blood cells, there are infection fighters. So if their white blood cell count is low, you know that your patient is at a high risk for developing an infection, because white blood cells are responsible for fighting invading pathogens. So that information is important when you think about how to care for your patient, how to protect him or her from potential infections. And it's your duty as a nurse to report anything abnormal about your patient to the physician. And that might be an abnormal assessment finding, it might be an abnormal lab or an abnormal diagnostic test. It is your responsibility in the role of a nurse to take care of your patient. Make sure that doctor is aware, because you'll be surprised. Sometimes you're the first one that finds out. So you need to make sure that doctor is aware of it and is taking action. Techniques used to gather data in the assessment step. I'm not going to cover this too much in detail because it was covered in chapter 21, that physical assessment chapter. So you've got, you inspect with your eyes, auscultate with your ears, you listen, you palpate or touch or feel with your fingers, your hands, and then percussion, those tapping movements to detect abnormalities of the internal organs. Objective data So objective data is either a measurement like vital signs or labs, or it could be an observation. So objective data are those things that can be observed through the senses of the nurse. So the senses through hearing, sight, smell, touch. So one like mnemonic device to help you to remember objective data a little better, you can think objective starts with the O, observe starts with the O. So they are things that the nurse can observe through our senses, hearing, sight, smell, touch. Or it could be something that can be measured based on a scale, like vital signs, labs, or even assessment data. Head to toe assessment data is an objective data because we know what is the accepted standard of normal. We know what is considered normal in a physical assessment so that you can measure what is abnormal based on that scale. So objective data is detectable by an observer. So it's someone other than the patient, such as us, the nurse, or it can be measured or tested against that accepted standard, that standard of normal. So it's what someone other than the patient can see, hear, feel with their senses, and they could be obtained by observation or through our physical assessment. So some good examples of objective data are our vital signs. Great example. Laboratory values, anything having to do with assessment data that we collect, like their lung sounds, their bowel sounds, skin discoloration. So anything you obtain during your shift assessment. Subjective data is information that is known only to the patient. Subjective data is gathered from the patient telling you something that you as the nurse cannot use your 5 senses to measure. You know, although some clues to those symptoms may be observable, only the patient knows exactly how he or she is feeling in that moment. You know, sometimes subjective data, like with your care plans, if you run into a situation where maybe your patient is confused or maybe they are unable to speak for himself or herself, we would allow you to get subjective data from family members or like a member of the nursing staff that knows the patient very well in that case. You know, so it can be tricky to gather if your patient is not able to communicate well. So the best things for subjective data are patient quotes. Make excellent subjective data, like, I feel nervous when my family leaves me alone. So you could use quotes from family and nursing staff as well. In certain cases, it's only acceptable when the patient is not able to describe to you how he or she is feeling. Another example, you know, the patient describes their pain to you. You know, that is subjective because the patient is telling you what their pain is. Like a dull, constant ache in the lower back, and it worsens while they're ambulating or walking. Another example of subjective data, feeling of worry or anxiety, feeling short of breath, nauseous, depressed, feeling discouraged. For subjective data, Some questions you can ask yourself are, did the patient tell me this information? Or can I measure or observe this information by myself? Is this something I can observe using my 5 senses? And has this patient told me this information, and can I verify it? So this is just a helpful picture for you covering subjective versus objective data. So it has subjective here in the green, and it's anything stated that cannot be verified from the nurse. It can't be verified using our 5 senses. It has to do with the patient's feelings or pain. Remember, the patient's the only one that can tell you how he or she is feeling. You know, some other examples are the patient feels dizzy. The patient reports falling down the stairs. Those are all examples of subjective data. Objective data is based on a measured scale or obtained through the nurse's 5 senses. You know, that has to do with vital signs like heart rate, or assessment data like I note that the patient is bleeding. Those would be examples of objective data. During the patient interview in the assessment step of the nursing process, you're going to obtain information oftentimes from more than one source. So note that when the patient provides the information to you, it is called primary data. And any information obtained from the family members, friends, or the patient's chart is considered secondary data. Step 2 of the nursing process, remember, is diagnosis. So you formulate your nursing diagnosis through analyzing the assessment information that you've gathered. So you have to analyze your data, compare your data against standards, cluster your important data, only collect those ingredients that will make that cupcake that you are wanting to make. You know, only that important information that goes with your nursing diagnosis that supports it. Identify gaps and inconsistencies in data, if that's the case. So you want to cluster your objective and subjective data that you've collected, and it will help you select the most appropriate nursing diagnosis for your patient. You always want to make sure that you have enough measurable supporting evidence or objective data to justify your nursing diagnosis. Like, yeah, I want to make this cupcake, but if I don't have enough ingredients, I'm not going to be able to. So remember, the nursing diagnosis is related to the needs or problems the patient is experiencing. Formulation of nursing diagnoses occurs in this diagnosis step. So this is where your nursing diagnosis handbook will come in handy. And later on in this slideshow, I'm actually going to have you pull out your nursing diagnosis handbook, and I'm going to be directing you to certain page numbers in the group, in the book, excuse me. And I will help you learn how to piece together a nursing diagnosis. So just remember, in this diagnosis step, that's when that diagnosis handbook comes in handy, and you're choosing a nursing diagnosis based on your patient. The defining characteristics will be listed when you look up the different nursing diagnoses, and you're going to compare what you identified in your assessment with the information in the textbook. Does it fit your patient? Does it fit your patient? Does your evidence that you've gathered during the assessment stage support that nursing diagnosis? If not, we would select another one. If yes, If it seems to fit them well, then that would be a good nursing diagnosis for him or her. So in other words, do the signs and symptoms that your patient is having match the information that is in your nursing diagnosis handbook? Is it a good choice for your patient? So if not, we can choose a better fitting nursing diagnosis that uses all of your supporting evidence that you've gathered in step 1, assessment. Step 3 of the nursing process is planning. So planning is the process of determining priorities and what nursing actions should be performed to help resolve or manage each of the patient's problems. So in the planning step, our plan is what we intend to do for our patient. It's like our roadmap for our patient's plan of care. So if a patient is 1 day post-op, then the plan might be to get her out of bed to a chair 2 times a day. If she has pain issues, then the plan might be to administer pain medication and then reevaluate her pain level. So planning is a very important step of the nursing process. So now you have all your data from the assessment step. You've made a nursing diagnosis. Well, now what? What do I do? I need to formulate a plan, my roadmap. I need to determine what goals I want my patient to meet. And goals are what we call expected outcomes. Expected outcome statement is a little bit more detailed than a typical goal. You know, it needs to be realistic for the patient. It needs to be patient-centered. It needs to be measurable based on a scale, like it needs to be objective. And it needs to have a definite time frame that is realistic for the patient. You never want to set your patient up to fail. So once you do that, once you set your expected outcome statements, the nurse then decides on the appropriate interventions to resolve each patient problem or nursing diagnosis. And we will go more into detail about how to write expected outcome statements in this slideshow. Remember, in the planning step, we're talking about the nurse creating patient goals or expected outcomes. Now, when I say a goal, a nursing goal is the overall or general direction in which one must progress to improve a problem. They can be either long-term or not expected to be met before the patient is discharged from the hospital or medical facility. It may be something that's more like an ongoing process of improvement or a gradual change in circumstances. A nursing goal could also be short-term in length, where it's expected to be met by discharge or by transfer to another level of care. Some examples of long-term care. For example, like by 12 weeks post-op, patient will have a full range of motion of right shoulder. Or patient will feed self using fork or spoon within the next 3 months. Those are examples of long-term goals. A short-term goal example might be patient will void within 6 hours after removal of Foley catheter. Or states relief of pain within 1 hour after receiving PO oxycodone. So while goal statements can be more general, our expected outcome statements are very specific. They contain a lot of detail. So expected outcomes are statements that must include 3 criteria. They must be measurable. The outcome should specifically describe the desired behavior so that it can be measured. When outcomes are measurable, observations can be made to determine whether they have been achieved or not. Your goals need to have a time frame. So the time for achievement of outcomes should be stated. For example, by the time of discharge, or by the end of the week, or within 48 hours, by post-op day 2. Outcome statements also need to be realistic. Outcomes should be achievable with available resources of the patient, nursing staff, and the acute care setting. So keep in mind such factors like finances, level of intelligence, and the patient's emotional and physical condition all play a factor. We need the goal to be realistic. The patient must be capable and willing and able to perform. You do not want to set your patients up to fail in any way to meet their goals, because then it would be unrealistic. They need to have a chance at achieving their goal. You should never set a goal too high. Start with small baby steps if you need to, rather than a big gigantic step all at once. You have to do what is best for your patients. And that brings me to my next point, that goals or outcome statements, expected outcome statements, need to be patient-oriented. So the outcome should be derived from the nursing diagnosis or the patient's problem, and the outcome needs to focus on the patient. The outcome statement should not be, surrounded by the needs of what the nurse needs to do. It does not need to be nurse-oriented, like teach the patient how to use a walker without assistance. That would be an incorrect example of an expected outcome statement, because it is something that the nurse needs to do for the patient. Teach them how to use the walker. Expected outcome statements need to be patient-oriented. So instead, we might do the patient will walk, 3 feet unassisted with a walker by Saturday. This would be correct. It is patient-specific, patient-oriented. Typically, the outcome statements are worded starting with the phrase, the patient will, or the resident will if you're in long-term care, or the client will. So a good example of a well-written expected outcome statement might be, the patient will be able to ambulate to the bathroom with one-person assistance using his walker at least once a day by the end of the week. And this is good. Let's break this down here. The patient will, so we know this expected outcome is patient-oriented. What do we want them to do? We want them to ambulate to the bathroom. Well, if we left it just like that and just we want the patient to be able to ambulate to the bathroom, it would not be measurable in any way. How? Describe how you want them to ambulate to the bathroom. We would like them to ambulate to the bathroom with one-person assistance, and of course using his walker, and we want them to do it once a day. It's very measurable because you are listing out how you want them to ambulate to the bathroom. We want it one-person assist, using the walker once a day, and then it has a time frame by the end of the week. Expected outcomes are statements of measurable action for the patient that have a specific time frame, and they are in response to nursing interventions. According to the ANA standards of practice, expected outcomes are to be developed by the registered nurse. They need to be first initiated or first started by a registered nurse, an RN. Now, the LPN is going to highly contribute information, assessment data, and provide input for the RN to make these goals, and they will contribute to writing the care plan. The RN is the one that has to initiate the care plan and set the expected outcome statements, and then the LPN can do anything else throughout that care plan. They can carry out all the other steps of the nursing process. Step 4 of the nursing process is implementation. So this is where we hop into action to resolve the patient's problems, which are the nursing diagnoses. So those actions that we take as nurses are called interventions. And when the nurse performs those interventions, it's called implementation. We are implementing. We are trying to implement the plan, put the plan to action to help resolve the patient's problems. The intervention should be clearly written so that everyone in the client's chart, everyone involved in the client's care knows how to care for the client. So it's like your roadmap. The clearer the map, the easier it will be to get to the destination. So in this case, the destination would be to accomplish the goals that the client wants to accomplish. During the implementation phase of the nursing process, nurses must work together as well as with other healthcare professionals to accomplish established goals and outcomes. Nursing interventions may involve direct or indirect patient care. Direct patient care is performed when the nurse interacts directly with the patient. So that would include activities like bathing, teaching, listening and communicating with the patient, as well as administering their medications, for example. Direct patient care is performed when the nurse provides assistance in a setting other than with the patient. So some examples of indirect patient care might be like documenting our care, participating in care conferences about our patient, talking with the healthcare provider, and receiving new healthcare providers' orders. Nursing interventions can also be classified as independent, dependent, or collaborative. So when nurses determine that interventions are needed, they may be able to provide the intervention without even consulting anyone else. So those would be what we would call independent interventions, because the physician's order is not required to perform them. So one example of this type of independent intervention is when a nurse assesses a patient's urine and we notice that it's very dark concentrated yellow and the amount of urine is much lower than normal. The nurse decides to put the patient on strict intake and output measurement because the patient has an increased risk for imbalanced fluid volume. So this nursing action is something that the nurse is using judgment for, and it does not require a physician's order, but instead it's a nursing order. It's something that we can do independently as nurses, and it's a way for us to obtain more data about the patient's possible problems. Now, some nursing interventions do require a healthcare provider's order before they can be performed. Those are referred to as dependent interventions. So, for example, if you have a patient that was complaining of constipation, the nurse would assess the date of the last bowel movement, assess their abdomen. The nurse could use some independent interventions to help promote peristalsis, that wave-like movement in the GI tract. And we can do that, such as, assisting with ambulation, or increasing fluid intake, assuming that this is permitted per the doctor's orders. The nurse also could administer laxatives or stool softeners, but we need to get a doctor's order before we can administer those. So that would be a dependent intervention. The nurse will have to call the doctor and get an order for a laxative, a stool softener, or an enema or something of that sort. So further orders were needed in that situation, so that requires the nurse to call the healthcare provider to obtain an order for the patient. So there are certain things nurses always need an order for, and nurses always need an order from a healthcare provider for administering or changing a patient's diet, medications, activity level, any IV therapy, treatments, diagnostic tests, and for discharge. Interventions are also broken down even further, like you can have collaborative nursing interventions, and those are involving working with other healthcare professionals in the setting. And that could be like a physical therapist, a respiratory therapist, your social service workers, your dietitian. An example of a collaborative nursing intervention would be when the nurse caring for a resident in a long-term care facility learns that hospice has been called in to see the resident. So the hospice nurse provides certain types of care to the resident related to his or her terminal diagnosis. Now, there's also the nurse employed by the long-term care facility, and that nurse is providing care to the resident, and that includes meds and treatments. So those two nurses, the hospice nurse and the nurse in the long-term care facility, are working closely together to provide the best possible care to that terminally ill resident. So that is an example of a collaborative nursing intervention. We also have individualized nursing interventions. So in a world of computer lists and pre-printed actions for nursing diagnoses, it is very tempting to simply select nursing orders from a list of possible interventions without taking into account what is most appropriate for your particular patient, and without considering the patient's likes or dislikes, their needs. We call this cookie cutter care, and that just refers to treating all patients the same. And we know that cookie cutter care, treating them all the same, is extremely dangerous. That could lead to you missing cues about a patient's unique problems, and that's going to in turn lead to more adverse effects for the patient. It could throw them into a life-threatening situation. So individualized care for patients is crucial. We want to individualize it based on our patient's needs, based on not only their physical needs, but their psychological needs, their social needs, spiritual needs, and cultural. So your patient is not just a diagnosis. It doesn't matter if you have 2 patients with pneumonia. You cannot treat those 2 patients the same, even though they have the same medical diagnosis. So your patient is not just a diagnosis, and they are not just the person in room 537. But instead, they are a person with individual responses to being ill, and they are in a hospital or a clinic, a long-term care facility, etc. And it's important to remember that no 2 patients are the same. Everyone has their own individual needs. So even though some patients share the same medical diagnoses, their care should reflect their individual needs. Sometimes a nursing order is to carry out the healthcare provider's order. So, for example, a patient complains of moderate headache, which he or she attributes to just not sleeping well. The nursing orders include administering a back rub, keeping the patient's room quiet, dimming the lights. The nurse also administers 400 milligrams of ibuprofen, which is ordered by the healthcare provider for relief of mild to moderate pain. The nursing orders and the medical orders combine here to improve the patient's health status. So we are all working together in collaboration towards the same goal. We are striving for our patient's best well-being. Initial steps of nursing interventions. So this can be found on the inside back cover of your Fundamentals for Nursing Care textbook. So that's on the inside back cover of your textbook. So our initial steps before we do any skill, before we get started, is we check the chart for the order. Always double check the chart. Think critically about the order. So is it appropriate for our patients? Why or why not? And if not, well, we need to call the healthcare provider back. Gather the needed equipment or supplies. Knock before you enter the room. Make sure you smile, make eye contact with the patient, introduce yourself to the patient. So explain what you're about to do, the procedure, to the patient. Identify the patient using 2 methods, like name and date of birth, for instance. Check their allergies, especially if, like, you're doing a skill that might require latex or betadine. You will assess allergies first prior to performing that skill. We're going to reevaluate the appropriateness of the intervention, so we're thinking critically about it again. Ensuring appropriateness of the environmental temperature to ensure just the comfort of the patient. Provide privacy for the patient. Remember, like when you're doing a head-to-toe assessment, just only uncover the part of the body that you are working with in that moment, just to protect their modesty and make the patient more comfortable. Perform your hand hygiene, don your gloves and protective equipment. Make sure you raise the bed to a comfortable level. Ending steps of nursing interventions. So these are things that we're going to be doing when we are getting ready to leave the room. We are finished providing our care. First, we're going to evaluate the patient's response to the procedure. We want to ensure the patient's safety. We want to ensure that they are comfortable in proper body alignment, that they have clean linens and their call light is within reach. We're going to do our safety checks, lower the bed to the lowest height to reduce the risk of falls. Raise your bed rails as appropriate. Ensure non-skid socks are on the patient's feet to prevent slipping, prevent falls. Make sure the walking pathway, especially if they get up to the restroom or the bedside commode, make sure that walking pathway is free of clutter. Perform hand hygiene. We're going to ask if the patient and the family needs anything and inform them when we plan to return. We're going to ask the patient their preference about would they like their door open or closed or slightly ajar. Document our interventions and the effectiveness according to our facility policy. And lastly, we're going to dispose of used supplies properly, as well as PPE and trash. We're going to return equipment to the proper location as well. Step 5 of the nursing process is our evaluation stage. So evaluation is performed when the nurse reflects on the interventions that he or she has performed, and we decide if it helped bring our patient closer to achieving our outcomes set in the planning step. If not, We as the nurses may have to revise and change the interventions, or perhaps even change the goals to better fit the needs of the patient. So we're asking ourselves questions like, were the outcomes met or not met? Is an additional assessment needed? Were the outcomes attainable for the patient? Were they realistic? Was the correct nursing diagnosis selected? And does my nursing care plan need to be revised? During the evaluation stage, this is where the nurse decides whether we need to terminate the plan of care. Maybe the patient has met their goals and they have progressed so much that we don't need that nursing diagnosis anymore. It's been resolved. So we're going to terminate it in that case. Maybe they want to modify the plan of care. Maybe we just need to tweak a few things, change a few interventions, or change a few goals. Maybe we think we picked a goal that was too high of a level for the patient, so we need to make it more realistic for him or her, just so they have more of a chance at meeting the goal. Or maybe we need to continue the plan of care just like it is. The patient just needs some more time. On this slide, we're going to cover the differences between medical diagnoses versus nursing diagnoses. So medical diagnoses are made by the physician, and they are based on signs, symptoms, lab findings, and test results. So the medical diagnosis is done by the physician, and it remains constant until a cure is effected. And an example of a medical diagnosis might be breast cancer. So the medical diagnosis is where the MD identifies conditions that the MD is licensed and qualified to treat. Medical diagnoses are focused on illness, injury, or disease. Whereas nursing diagnoses identify situations the nurse is licensed and qualified to treat. The nursing diagnosis changes as the client's response changes and or the health problem changes. Just like in that evaluation step in the previous slide, we talked about how our plan of care can adapt and change. Nursing diagnoses focuses on the patient's responses to actual or potential problems. And we're going to talk about different types of nursing diagnoses in this slideshow. Some examples of nursing diagnoses might be knowledge deficit, powerlessness, anticipatory grieving, body image disturbance, ineffective coping. One helpful tool for determining priority is called Maslow's hierarchy of human needs. This pyramid identifies human needs in an ascending order of importance. So priority goes from bottom to top. The first level of the pyramid on the bottom, which would also be the highest priority, is physiological needs. So those are things that a human being needs to survive, such as food, air, and water. The next level addresses safety and security needs, those things a human being needs to remain alive and protected and feel safe. The third level includes the need for love and belonging. So this would be like meaningful relationships, giving and receiving affection and feeling like you belong to a group. The next level is the need for self-esteem and feelings of self-worth. So this is the self-esteem tier, where they have a sense of pride, a sense of accomplishment, and receive recognition by others. This is followed by the level that addresses cognitive needs for learning and exploring. They have the knowledge and understanding. The sixth level is composed of aesthetic needs for beauty and order. They're able to appreciate the beauty in the world and their environment. The seventh level addresses the need for self-actualization. So that is the need for reaching one's own growth potential. So that is reaching their best potential. And this is rare for most patients to meet. Most people, including ourselves, are still working towards self-actualization. Something that takes a lot of work to reach. So your patient may not meet these top two tiers here. Now this top tier is called transcendence. This is the highest level, and this is the need to help others reach their highest potential. So transcendence refers to helping another person reach self-actualization, their best, fullest potential. So there again, your patients will likely not meet these top two tiers of self-actualization or transcendence, and that is okay. We are reaching that ourselves as human beings, constantly striving to improve. So here you will see I split this pyramid that is in your book on page 53, and I drew a line through mine. See, these bottom four tiers here are basic human needs. Remember that the priority goes from bottom to top. So physiological needs are those needs that humans need to be able to survive, followed by safety and security, love and belonging, and self-esteem. Further up in the pyramid, we have higher order needs, which are what we call growth needs, constantly striving for growth. Our cognitive needs to learn and explore. Aesthetic needs for appreciating the beauty of life. Self-actualization for striving towards our best potential, our best personal growth. And transcendence, helping others to reach their highest potential. This pyramid, Maslow's hierarchy of needs, can be used to help select your highest priority nursing diagnoses. Maslow's hierarchy was created by Abraham Maslow, and he was an American psychologist. And he stated that humans must meet their physiological needs first, before needs on the higher steps can be addressed. For example, a homeless person is focused on finding food and shelter in a safe area and would not be interested in joining a self-help group until his or her basic needs have been met first. So nurses must address the physiological needs of survival first with their patients, and then the needs related to relationship issues in the love and belonging tier, and then issues in the higher order needs like personal growth. Another example in a hospital setting is a patient who has recently undergone an abdominal surgery, and it's causing him or her to be in so much pain that they are not able to sleep well. The patient would not be ready or able to learn how to perform a dressing change on his or her abdominal wound until the basic physiological human needs of pain relief and rest have been met first. So I actually want to take Maslow's hierarchy, that pyramid we were just discussing, and take it to the next level. Let's take it to a step up. Let's apply Maslow's hierarchy and use it as a test-taking strategy. So we can use Maslow's to our advantage when we are taking NCLEX type questions on a test, and use it as a test-taking strategy if the question is asking you about what the patient needs and you're trying to determine which needs are priority. So step 1, we're going to look at our answer choices and determine if the answer choices are both physiological or bottom tier basic human needs, or if they're psychosocial, more like the top part of the pyramid. If they are, you can apply the Maslow's test-taking strategy. Step 2, we're going to eliminate all psychosocial answer choices here, because remember, we're trying to determine priority. So if the answer is physiological, that bottom tier of Maslow's, do not eliminate it yet. I want you to keep it. So remember, in the back of your head, if Maslow's states that physiological needs must be met first, that is going to be your priority. Step 3, look at each of the answer choices that you have not yet eliminated. So these are all going to be physiological or basic human needs, the bottom tier of Maslow's. And we just want to ask ourselves, do these answer options make sense with regard to the disease or situation described in the question scenario? If it makes sense as an answer choice, make sure you keep it for consideration and go on to the next choice. So you're breaking it down. You're looking at each answer option individually, asking yourself, does this make sense? Does it match what my question is asking me? And one thing you can do is reword that question in verbiage that you can easily understand and make sure you understand what the question is asking. Step 4. So once you have all your physiological needs, you can ask yourself, can I apply the ABCs here? So remember that your ABCs stand for airway, breathing, and circulation. So if there's an answer that involves maintaining a patent airway, that's going to be correct because that is priority. So if there is not an airway option, maybe there's a choice that involves a breathing problem. If there's no breathing problems listed in the answer options, perhaps there is an answer pertaining to the cardiovascular system, talking about our circulation. If so, that might be correct. So you're going to move on down the ABCs and analyze your answer options. Now, sometimes you may get a question that your ABCs cannot apply. So with that, you're just going to compare your remaining physiological answer choices and ask yourself, what is the highest priority here? And that will help lead you to your answer. And all this information on this slide here came from Kaplan, which is a great NCLEX book. And they teach great NCLEX review courses and things like that. They have lots of books that you could look into. Now, I want to take what we have learned from the previous slide and apply it to the sample question here. So we have a nurse who's reviewing the plan of care for a pregnant client with a diagnosis of sickle cell anemia. Which nursing diagnosis, if stated on the plan of care, would the nurse select as receiving the highest priority? A, anxiety, ineffective coping, disturbed body image, or deficient fluid volume. So even without knowing anything about pregnant clients or sickle cell anemia, you can come up with the right answer here. And you know how? Maslow's hierarchy of needs. So note the keywords highest priority here in the question stem. Highest priority. Use Maslow's hierarchy of needs to prioritize. So remember that physiological needs come first. Using this guideline, you can go ahead and omit anything that is psychological, psychosocial, like anxiety. Ineffective coping is psychological or psychosocial. And disturbed body image is also psychosocial. That leaves you to answer option D, deficient fluid volume. So deficient fluid volume is the only physiological need that is listed here, and therefore it is priority. It is bottom tier of Maslow's. Remember that priority goes from bottom to top of that pyramid. So here is my sample question number 2 of applying Maslow's as a test-taking strategy. So here, you have a nurse that's obtaining a diet history from a pregnant 16-year-old girl. The girl tells the nurse that her typical daily diet includes cereal and milk for breakfast, pizza and soda for lunch, a cheeseburger, milkshake, fries, and salad for dinner. Which of the following is the most accurate nursing diagnosis based on this data? So notice from the question stem, always recognize your key words in your question stem. Most accurate. This alerts you that there may be more than one answer choice here that could be considered correct. But only one of them is the most accurate. Only one of them is the best answer. So step 1, I want you to look at all the answer choices here, and you're going to see that there are both physical and psychosocial interventions here. So we know that we can apply the Maslow's test-taking strategy here. Eliminate all psychosocial answer choices. So we want to eliminate all the options that are psychosocial. So in that case, it means knowledge deficit, right? That is a psychosocial need. We're going to eliminate that option. Ask yourself, do these remaining answer choices make sense? So let's break it down. We got option A that says altered nutrition, more than body requirements related to high fat intake. Does it make sense? I would say yes. Her diet is very high in fat. So I'm going to keep this answer option here. I'm going to go down to option C. Altered nutrition, less than body requirements related to an increased nutritional demands of pregnancy. I would say yes, this also makes sense. This diet has an adequate number of calories, but it is deficient in the need for vitamins and minerals. So we are going to keep answer option C. Now we're going to look at option D, risk for injury, fetal malnutrition related to poor maternal diet. Ask yourself, does this make sense? No, this does not make sense. There is an adequate number of calories to support fetal growth, so I am going to eliminate this option. You now have eliminated 2 of the possible choices. So let's proceed. So step 4 is you take your remaining options left and ask yourself, can I apply the ABCs to these choices? Are there anything telling us that we can use airway, breathing, circulation? No, there is not. So now we just need to compare the answer choices to the question stem. Does it make sense as far as the scenario and what the question is asking me? Which one of these answers best fits this scenario? Which is higher priority? So option A, and I'm going to reword it, option A, the fact that this 16-year-old's diet contains too much fat, that's what answer A is talking about. Or the fact that the diet does not have enough nutrients, like answer option C. So when you think about it that way, which is higher priority? The fact that her diet is too fatty, or the fact that her diet does not have enough nutrients for that baby? So insufficient nutrients is, of course, going to be the higher priority. So the correct answer here is going to be C. All right, so we got one more sample question about applying Maslow's. That's just slightly different than the previous two sample questions. So here we go. We got a client with a diagnosis of cancer, and they are receiving a morphine sulfate, 10 milligrams subcutaneously every 3 to 4 hours for pain. When preparing the plan of care for the client, the nurse includes which priority action? Take note of the key word in the question stem, priority. Since all these options are physiological, basic human needs, bottom tier of Maslow's, ask yourself, can I use ABCs here? That will help me figure out the priority: airway, breathing, and circulation. So one thing to recall, that morphine sulfate suppresses the cough reflex and the respiratory reflex. Ask yourself here, is there an option that deals with the airway or breathing? And you can see there is. Encourage the client to cough and deep breathe. So this is going to be priority because it addresses the airway, coughing to clear the airway, and deep breathing. If you don't have a patent airway, you are not going to be able to breathe sufficiently. So answer C is our correct option here. And we got there by using our ABC, since we know that all these answer options are physiological, bottom tier of Maslow's. So we applied the ABCs. According to the ANA Standards of Practice for Registered Nurses, all steps of the nursing process from assessment through evaluation are the responsibility of the registered nurse, the RN. This includes outcome identification in addition to planning. So initiating the care plan, setting the nursing diagnosis, like initiating the nursing diagnosis and identifying the goals are the RN's responsibility. They are the ones writing the care plan for the first time. Now the LPN, the licensed practical nurse, participates directly in all the remaining steps of planning, intervention, evaluation, and the RN is likely going to have the LPN do an assessment, and they may verify their assessment data and get their input as far as what they feel like would be a good goal for the patient. See, the RN and LPN work together. Even though the LPN's not the one initiating the care plan or initially writing the goals, the RN and the LPN are working hand in hand here through the steps of the nursing process. So this does not mean at all that the LPN cannot perform assessment skills, but it does mean that the findings that the LPN provides are shared with and sometimes confirmed by the RN.
The same is true of formulating a nursing diagnosis. So the LPN contributes greatly to the development of the nursing diagnosis by providing input. But it is the RN that is doing the documenting. They are the ones initially creating the care plan. All data and information gathered by all nurses are considered when a nursing diagnosis is being identified and prioritized. So LPNs in Georgia cannot initiate a care plan, but they're very involved in the rest of the nursing process. The LPN contributes greatly to the development of the nursing diagnosis. They're providing the RN with the assessment data, all those important information that they gathered. All members of the healthcare team contribute to providing quality care for patients. And I want you to remember this right here. No one, from the housekeeping staff to the director of nursing, is less valuable than anyone else when it comes to providing care for patients. You are to treat everyone with utmost respect. So when you decide upon your nursing diagnosis and you prioritize your care by following the nursing process and having those outcomes in mind, it orders your steps in a way. You really have goals in mind to help the patient progress to discharge. So it's all about helping your patient improve and progress rather than just you getting through your shift. The goal is for the patient to progress, not for you to complete your shift. Just because your meds were passed and your patients were assessed and charted on doesn't mean you provided good nursing care. And I want you to, for instance, take this example. Imagine you are married to the love of your life, and we're going to call him Alex. Now, Alex is the love of your life. They're your yin to your yang. And imagine they broke their femur in a bicycling accident, and they had urgent surgery, and they're on an orthopedic floor. You've got Nurse A here that walks in, gets her report, looks at the chart, goes back to work. They pass their meds on time. They give Alex IV pain meds whenever he wants it. Draws labs when they're ordered. Helps Alex to the bathroom. Although Alex spent about 80% of the day in bed because the pain meds made him really sleepy. Nurse A answers questions when asked, but they don't really explain anything. At the end of the day, they give the next shift report and they leave. They go home. At the end of the day, Alex still needs pain meds frequently. He felt groggy all day long. He barely got up. He was in bed practically all day and didn't eat much. He or she needs a decent amount of help getting up and sitting down whenever using the restroom, and it hasn't seemed to improve a whole lot. Dr. Smith, who operated on Alex right upon admission, rounded towards the end of the day while Alex was sleeping. She wrote the following progress note: transition to oral pain meds, increase ambulation, discharge in next 72 hours. Successful shift, right? Everything was technically done and completed on time, but does that mean they did a good job? Or you've got Nurse B over here that has got it going on. They walk in, they get report, they look at the chart. Nurse B decides that they need to focus on pain management here and promoting mobility in the patient so that he can progress, so that he is able to go home and can tolerate it. And she also wants to prevent skin breakdown. So those are going to be her outcomes that she's focusing on today, to get the love of your life home and doing better ASAP. So Nurse B looks closely at all the orders to make sure that they prioritize everything. Nurse B starts out the day by giving you and Alex the plan for the day. we're going to try to transition from IV to oral pain meds for a better, longer relief. Oral pain meds will last longer. It's really important to get out of bed as much as possible today, so we'll get at least 2 walks in, but hopefully 3. I want you out of bed for each meal, and we really want to make sure you're not sitting on your butt all day because your skin can start to break down. So if you decide to go to sleep, let's get some pillows and prop you up on your side and get some weight. Get some weight off if that's comfortable. Nurse B gave oral pain meds with the rest of Alex's meds at the beginning of shift. Nurse B made sure to get Alex up for all 3 meals and walked with him twice. And then when Alex said he wanted to take a nap in the afternoon, Nurse B came in, got him positioned on his side, took some pressure off with some pillows. Dr. Smith, who operated on Alex right upon admission, rounded towards the end of the day while Alex was up in a chair and eating dinner. She wrote the following in her progress note: "Continue current plan, discharge tomorrow." At the end of the shift, Alex has not needed another dose of IV pain meds despite all of the increased mobility. He walked twice. He was up to get out of the chair for all meals. Getting up the first few times was rough, but it got easier for him as the day progressed. By the end of the day, Alex was basically walking himself to the bathroom with the assistance of a walker and just standby assistance just in case. So tell me this, which nurse had a more productive and successful shift? They both passed their meds on time. They both responded to call lights and the needs by the patient, so all is well, right? Wrong. Nurse A got the tasks done for the shift, but they had no plan. Nurse A did not have discharge in mind. They were not taking into account the outcomes that they set for the patient. They didn't have any goals set for the patient. Nurse A just wanted to get to the end of the shift. Nurse B was proactive and had a plan. Nurse B had a care plan. Nurse B thought about the needs of a patient with a fractured femur and prioritized care for the day. Nurse B was a good communicator and made sure their patient progressed towards discharge. So which nurse do you want caring for your loved one? Nurse A or Nurse B? You want Nurse B, who had a care plan. Now we're going to start getting into writing nursing diagnoses, and this can be located on page 54 of your Fundamentals of Nursing Care textbook. So a complete nursing diagnosis may be 1-part, 2-part, or 3-part statement. We're going to talk about the 3-part statement in this slide. So the 3-part nursing diagnosis statement is called a PES statement. And this stands for the problem. That's a diagnostic concept or label based on the patient needs. Ask yourself, what's the problem based on the clustered data that I collected? Based on all of my data, I collected an assessment, step 1 of the nursing process. What is the patient's main problem to work on? Next is etiology. Causative factors connected to the diagnostic label by words related to. So etiology means what's the cause? What condition or process is the cause or the culprit for the problem? Next is signs and symptoms. Data collected and evidence used to support the diagnostic label. And it's linked to the statement by the words as evidenced by. You're going to use your objective data you clustered to support your nursing diagnosis. So I'm going to teach you how to put all 3 of these together and how to write out a nursing diagnosis statement. And we will talk about different types of nursing diagnoses in the next couple of slides.
So remember, we talked about how there's different types of nursing diagnoses. And this first one we're going to talk about is an actual nursing diagnosis. So this is a client problem that is present at the time of the nursing assessment. An actual nursing diagnosis represents a problem that has been validated by the presence of major defining characteristics. And these are listed in your nursing diagnosis handbook under each nursing diagnosis. And I'm going to, when we get down to the examples, walk you through how I wrote these two examples and how to find it in your nursing diagnosis handbook. Defining characteristics are signs and symptoms that, when clustered together, represent the nursing diagnosis. So actual nursing diagnoses are problems that are currently going on at the time that you do your nursing assessment. They require a three-part PES statement, which we talked about in the previous slide. Remember, P stands for the problem. So what is the current problem? And that would be your accepted NANDA nursing diagnosis, meaning it is coming from this nursing diagnosis handbook and it is approved. E for etiology, the cause, and S for signs and symptoms. NANDA nursing diagnoses are written in such a way, such verbiage, that they are NANDA approved. You have to use the verbiage in your nursing diagnosis handbook. Otherwise, it will not be an approved nursing diagnosis. So this first example that I have here is ineffective breathing pattern. So I am going to turn to that page right now. So I am working with the Nursing Diagnosis Handbook by Ackley and Ladwig from Elsevier, and I have the 12th edition. So if you have an older edition Nursing Diagnosis Handbook, it will work. It's just the page numbers that I'm calling out will be different. So you will have to look it up in the edition that you have. So this first example, ineffective breathing pattern, is located on page 185 of the 12th edition Nursing Diagnosis Handbook. That is page 185. Feel free to pause your recording here to locate ineffective breathing pattern in your nursing handbook. You can look up the keyword breathing to locate it. You're going to look it up in the pages that have all the purple boxes down the side of the white pages. You will look up the keyword breathing until you find ineffective breathing pattern. The next part of our nursing diagnosis is finding our etiology. So we've done our problem already. Our problem is ineffective breathing pattern. That's a current problem going on when I assessed my patient. Now I need to find out what the culprit is. What is causing that ineffective breathing pattern? Remember that it is connected to the problem statement by using related to, and you can shorten it by doing R/T. If you have turned to page 185 of your nursing diagnosis handbook, remember I'm using the 12th edition, you can look under related factors. So under related factors, take a look at all of those things listed there on the page. Does anything pop out at you that it matches your patient? You need to pick something that goes with your patient. Remember, we are individualizing our care here. So for this instance, I'm just teaching you how to write the statement now. I just picked respiratory muscle fatigue. So this would be my etiology that is causing my ineffective breathing pattern, and that is my E. Excuse my poor handwriting. on this thing. I'm doing the best I can. And now we need to do our last part of our statement. Since actual nursing diagnoses have three parts, we need the signs and symptoms, and that is connected to the related statement by as evidenced by. So your signs and symptoms is connected to your etiology by as evidenced by. This is my evidence that I collected through my nursing assessment that I have that supports that the patient does indeed have ineffective breathing pattern. So now in my nursing diagnosis handbook, still on page 185, I'm going to look and see where they have that heading in purple letters there, and it says defining characteristics. Defining characteristics. So it's listing out all these characteristics, all these signs and symptoms the patient could have that would prove the patient has ineffective breathing pattern. So right now I just picked a couple out. Alterations in breathing pattern, the use of accessory muscles to breathe, and dyspnea. So now I have a three-part statement. I have a problem, etiology, and signs and symptoms. Now we're going to turn to page 412 in the 12th edition Nursing Diagnosis Handbook. Please turn to page 412. Feel free to pause your video here and locate excess fluid volume. Look up the keyword fluid in your Nursing Diagnosis Handbook, and that will be under the white pages with the little purple boxes. Look up the word fluid until you find excess fluid volume. In the 12th edition, it's on page 412. It would be helpful if you would go pull your book out and have a visual as I'm speaking. So when you pull out your Nursing Diagnosis Handbook, on page 412, you'll see it gives you a definition, and that is surplus intake and or retention of fluid. So excess fluid volume is the problem. We connect the problem to our etiology or our cause by using related to. Now remember, for related to in the handbook, we can look up the heading related factors. So see the heading related factors, and I just picked out excess fluid intake. So I'm picking excess fluid intake as being the cause for excess fluid volume because I feel like that best fits my patient after I assessed him or her. Now we're going to connect the etiology with the signs and symptoms. Remember, we need a PES statement. So we connect that by using the words as evidenced by. These are the evidence that I have gathered as the nurse that can back up the excess fluid volume, that can back up the problem. So in your Nursing Diagnosis Handbook on page 412, you're going to look up the heading Defining Characteristics. So on page 412, you will see a heading called Defining Characteristics, and you will look through those and pick any ones that you feel like best matches your patient. You want to individualize it to your individual patient. And you don't have to go with everything in the book. If you have something else you want to add that is not in the book, but it goes with your nursing diagnosis, feel free to add it as long as everything goes together. So this would be your signs and symptoms. So we're going to be doing a care plan workshop on each campus where we will work in detail with you guys and help you practice, and it'll be an interactive lesson where you learn how to write care plans based on a patient scenario. Psychosocial nursing diagnoses are also a three-part nursing statement, just like your actual nursing diagnosis statement was in the previous slide. So it is also a PES statement: problem, etiology, signs, and symptoms. Psychosocial nursing diagnoses are often used with patients who have diseases like depression, bipolar disorder, anorexia, bulimia, substance or alcohol abuse, have attempted or thinking of suicide, have death or dying issues, coping and self-esteem issues, behavioral issues. It can also include stress. So all those things are psychosocial because they have to do with how patients deal with life events and life processes. So one example that we chose out of the Nursing Diagnosis Handbook is powerlessness. Please get out your Nursing Diagnosis Handbook and turn to page 724. That's page 724 in the 12th edition Nursing Diagnosis Handbook. If you have an older edition, please locate the keyword powerlessness and look it up in your Nursing Diagnosis Handbook. Please pause the video as necessary. So powerlessness in this instance is our problem statement. It's our psychosocial problem. We connect our problem with our etiology by using related to. Our etiology, or our cause, can be looked up in the Nursing Diagnosis Handbook on page 725. Page 725 of the 12th edition Nursing Diagnosis Handbook. And we are going to look under related factors. So these are the possible causes or the culprit, what might be causing the powerlessness. And in this particular example, we selected insufficient social support. That is what we feel is causing the patient to feel powerless. Now we're going to connect the etiology with the signs and symptoms. And we're going to do that by using the connector as evidenced by. Now we are going to take our assessment data that we have clustered, our pertinent subjective and objective data, and only choose the ones that we feel best supports our nursing diagnosis of powerlessness. And in this instance, we can look at defining characteristics in the Nursing Diagnosis Handbook. On page 725, under defining characteristics, it will give you some examples of signs and symptoms that you can choose. But there again, don't get caught up in only writing what's in the book. Make it your own. Make it fit your patient. Individualize it. My patient verbalized feeling alienated by family, and they are depressed and having shame. So that is the signs and symptoms. So that is a completed psychosocial nursing diagnosis. It's a three-part problem, etiology, and signs and symptoms statement, PES statement. So just like your actual nursing diagnosis, psychosocial nursing diagnoses also contain three parts when you're writing out your nursing diagnosis statement. Now we are going to cover another type of nursing diagnosis, a risk for or potential nursing diagnosis. This is a little different from the previous two that we have covered. Those two had three parts. A risk for nursing diagnosis is only a two-part nursing diagnosis statement. A risk for nursing diagnosis is for when there is a risk for a problem or the potential for a problem to develop. A risk for nursing diagnosis is a clinical judgment that a problem does not yet exist. Therefore, there are no signs and symptoms present. That is why there is no S as part of the statement. There is only the problem and the etiology. So, let me get my pen out here. It is a PE statement. Risk for nursing diagnoses are PE statements. There is no S because the problem has not yet occurred. It has not yet developed. It doesn't exist yet, so there's no signs and symptoms to list. However, there is a presence of risk factors that indicates that the problem is likely to develop unless the nurse intervenes or does something about it. For risk for nursing diagnoses, there are no related factors, causative factors, because we are identifying a vulnerability in a patient for a potential problem. The problem is not yet present. Therefore, we identify risk factors that predispose the individual to a potential problem. So risk for infection is the particular example that we selected. So please pull out your nursing diagnosis handbook and turn to page 546. Page 546 in the 12th edition Nursing Diagnosis Handbook. If you have an older edition, please pause the video and look for the keyword infection until you locate risk for infection. Now, once you have found risk for infection, you need to do the related to part. What is it related to? Well, it's related to our risk factors in this case. The problem has not yet occurred. So we're going to pick things that predispose the patient to being at risk for infection. Now you notice this page looks slightly different just because it says risk factors instead of related factors. So under risk factors, under that heading, under risk for infection, you'll notice one of the things says inadequate vaccination, and I also selected one of the associated conditions under that heading. So under the associated condition heading, you will see immunosuppression as one of the possible risk factors that can predispose somebody to being at risk for infection. So that is the entire risk for statement right there. You have a problem, and then you have a set of risk factors. Remember, there are no signs and symptoms in a risk for nursing diagnosis because the problem does not yet exist. The problem has not yet occurred, but it's likely to develop if we don't do something about it. Wellness nursing diagnoses are another type of nursing diagnosis. Now, we're not going to be working with these so much throughout this PN program, but it is something that we want to present to you and we want you to be aware of. Wellness nursing diagnoses focus on the patient's progress or potential progress towards healthier behaviors rather than a problem. So the patient is actually functioning effectively, but they actually desire a higher level of wellness. A wellness diagnosis indicates a readiness to advance from the current level of health to a higher level of health.
There are two prerequisites for a wellness diagnosis. They must have a desire to advance and an ability to do so. So wellness diagnoses are useful for healthy clients, like school children or new parents who require teaching for health promotion, disease prevention, and personal growth. These types of diagnostic statements do not contain related factors, but they just contain the label only. It's just a one-part statement. For example, a readiness for enhanced spiritual well-being. Now, you will not be writing any wellness diagnoses throughout this program, but we do want you to recognize this. These are some other one-part diagnostic statements. Now, you're not going to be writing any of these examples here, but we do want to present them to you so you're familiar with them. We covered the wellness diagnosis on the previous slide. The next one is syndrome diagnoses. So they label a group of signs or symptoms, what we call defining characteristics. So the syndrome diagnoses already refer to defining characteristics, and they don't need further elaboration or clarification. So examples are post-trauma syndrome and rape trauma syndrome. Those are syndrome diagnoses. There again, you won't be writing these throughout this program. We just want to present them to you. Specified diagnoses are those that clearly apply to one defined patient need, so that any more description would only be redundant. So it's just one part, like latex allergy response. There's no need to say related to allergy to latex because it's redundant. It's already stated here in this one part statement. This is just simply a summary of the different types of nursing diagnoses that we've covered. So we have our actual diagnoses. That is a three-part statement. Also, I want you to remember your psychosocial is also a three-part. I'm just going to write psych by here to trigger your memory. Sorry for my bad handwriting on this computer. So three-part nursing diagnosis statements are your actual nursing diagnosis and psychosocial nursing diagnoses. Our two-part nursing diagnosis statements are our risk for nursing diagnoses. And then remember the one part we said we are not going to be working closely with during this program, but that would be like your wellness diagnoses that we covered on the previous slide. Now we're going to cover different types of nursing care plans. So we have computerized care plans that have become more popular now as more facilities are charting electronically. So in most hospitals, computerized care plans are the standard. The RN highlights or checks appropriate nursing diagnoses on the computer screen and selects corresponding goals and nursing interventions listed for that diagnosis. The care plan is saved in the computer and may not be printed out. It is available to all nursing staff with computer passwords, and they use the standardized language for nursing diagnoses, which is NANDA. So you always want to turn off or shut down the computer monitor screen so that people cannot see the patient's private information. So that is computerized care plans. The next one is standardized care plans. So those are pre-printed documents that have typical nursing diagnoses and corresponding nursing intervention choices to coordinate with a particular medical diagnosis. So they are pre-printed for you. It's not very individualized.
It is standardized. So, for example, a standardized care plan for a patient with pneumonia might include choices of the following nursing diagnoses: ineffective airway clearance, impaired gas exchange, activity intolerance, etc. The nurse checks the nursing diagnoses that match the assessment data and selects from listed interventions on that pre-printed document what they feel is appropriate for their patient. Some standardized care plans do provide the opportunity to individualize further, so they'll give you a space to write details or dates in blank spaces. So an advantage to these standardized care plans is that they help you remember most of the interventions for a specific diagnosis, so it helps prevent any oversight. Multidisciplinary care plans is another type that's frequently used in hospitals because it is so collaborative and has to do with teamwork, our multidisciplinary plan of care. So it's not just nursing that's working with this, but it's also, our respiratory therapists, our social service workers, physical therapy, dietitians. So everyone's working in this care plan, all working together. One major advantage of the multidisciplinary care plan is that all healthcare professionals involved in the care are working and communicating well with one another. Critical pathways are similar to standardized care plans, except that they're based on the progression expected for each day the patient is in the hospital. So I always think of like a post-op patient, how it'll say, after post-op day 1, I want you to get them up in the chair. After post-op day 2, they need to walk so many feet down the hall, etc. So it's based on the progression expected for each day they're in the hospital. Certain nursing interventions are provided each day, and they can change as the patient improves and requires less comprehensive nursing care. So a critical pathway uses the average length of stay for a particular medical diagnosis as the basis for the progression of care. So if the patient has more than one major medical diagnosis, then it can become difficult to use a critical pathway. So it may not be the best choice if your patient has more than one problem going on. Student care plans. So this is what you guys will be writing here in nursing school. So for many years in nursing education, student care plans have been used to help students make connections between a patient's medical diagnoses, medications, lab and diagnostic tests, assessment data, nursing diagnoses and interventions, evaluations. So it is true that once you're out of school, you're no longer going to complete such lengthy, detailed care plans because of time constraints in the real world. However, while you are a nursing student, these care plans are essential, excellent tools for sharpening your critical thinking skills, and it enhances your nursing decision making. Writing these student care plans is one major way that you are going to learn how to think like a nurse, and that is your goal in nursing school, how to think like a nurse. Students that do well on their care plans from clinical, for example, tend to do well on their nursing exams as well. You know why? Because they are using that nursing process, that critical thinking, and they are seeing the whole patient, the whole picture of what is going on or what could potentially occur, and they are taking action. They are thinking like a nurse. This is the example of the nursing care plan worksheet that you will be working closely with throughout the program. As you can see, the care plan follows the steps of the nursing process. So see, you have your ADPI: assessment, diagnosis, interventions. We have a rationale for our interventions. Why are we doing these things we're doing? How is it going to help our patient? And evaluation. While you are preparing to care for patients prior to a clinical experience, you will want to become familiar with your patient's medical diagnoses, and that would include researching what are the likely problems or potential problems you need to know about his or her condition. What are the signs and symptoms of the condition? Which lab or diagnostic tests do you expect? What is the usual treatment? So this will help you learn more about diseases, diagnosis, and treatment in the medical surgical portion of your nursing education. Early on in school and when you're developing your experience, you're going to need to research medical diagnoses in your medical surgical textbook. The second step is deciding on possible nursing diagnoses that best fit your patient. So you're getting ideas about possible problems your patient might have. Then you're setting your expected outcome statement. Remember, they must be patient-centered, they must be realistic, the patient must be willing and able to perform, they must be measurable, and have a time frame. Step 4 is developing your interventions. So I'm going to determine what I need to do to help my patient. Step 5 is to meet and greet and assess your patient. Then you're going to evaluate your nursing diagnoses. Now that you've assessed your patient, do you need to make any changes to the nursing diagnoses that you developed previously? Do any other nursing diagnoses take priority over the ones that you previously written? Step 7 is taking action. Implement your nursing interventions. And step 8 is evaluating your care plan. Do you need to change your care plan in any way? Was it effective or not? Did the patient meet his or her goals? Why or why not? Or does the care plan need to stay the same? Maybe the care plan, the patient just needs more time to meet his or her goals. So step 8 is to evaluate. Next, we're going to talk about concept maps, and this is another topic that we want to present you. We want you to familiarize yourself with it, but you will not be writing concept maps in this program. We do the care plan worksheet format. So concept maps, we do want to introduce it to you. They are also known as mind maps, and they can be used to diagram and connect data about any subject. They can be used to organize and plan nursing care. So when you use a concept map to plan care, you're still using the nursing process as your basis for decision making. It is essentially a care plan. It's just a different format. So now I want to teach you how to take that nursing process we discussed a step further and teach you how to apply it to NCLEX type questions. So the nursing process can be an excellent test-taking strategy. So we're going to discuss how we can use it as a test-taking strategy, just like we did with Maslow's hierarchy. So when you use the nursing process as a test-taking strategy, you are utilizing the assessment and implementation phases of the nursing process. So it's going to help you in selecting the correct answers to questions that ask you to identify priorities. So step 1, you want to read the answer choices and establish a pattern. If the answer choices are a mix of assessment and implementation, you know you can apply the nursing process here. Step 2, refer to the question to determine whether you should be assessing or implementing. Step 3, eliminate your answer choices and select the best answer. If after step 2 you find that, for example, it is an assessment question, you need to eliminate any answers that clearly focus on implementation. So always remember, you want to assess before you implement. So you have to determine if the nurse did any assessment in the question stem, and then you know in the options that you need to take some sort of action, you need to implement. This is our first sample question for using nursing process as a test-taking strategy. So you have a boy who was riding his bike to school when he hit the curb. He fell and hurt his leg. The school nurse was called and found him alert and conscious, but he was in severe pain and a possible fracture of the right femur. Which of the following is the first action that the nurse should take? So make sure you pick out your keyword in the question stem first. Now, the words first action will tell you that this is a priority question. It's asking you what is number 1 priority. Always get in the habit of rewording the question stem in your head and ask yourself, what is this question really asking me? So put it in a verbiage that you can easily understand. So when I reword this, I say, what is the highest priority for a fractured femur? Step 1, read the answer choices to establish a pattern. So as you start to read these options, you will notice that they are a mix of assessment and implementation. So you know that you could apply the nursing process here in this question. You want to refer back to the question to determine whether you should be assessing or implementing. So according to the question, the nurse has determined that the boy has a possible fracture, and they also determined that he is alert and conscious, but he's in some severe pain. So that to me tells me that the nurse has done her assessment. She has done assessment. So now it's time for us to implement. We need to take action. So eliminate answer choices. You can eliminate options 2 and 4 because those deal with assessments. So this leaves you with choices 1 and 3. So ask yourself, which takes priority? Immobilizing the affected limb or placing the boy in a semi-Fowler's position to facilitate breathing? The question doesn't indicate any respiratory distress at all. Which one makes the most sense for this particular patient in this scenario? The correct answer is 1, immobilize the affected limb. Some students will choose an answer involving the ABCs without thinking it through first. But beware, use the ABCs to establish priorities, but make sure that the answer is appropriate to the situation. So in this particular question, breathing was mentioned in one of the answer choices. If you thought of the ABCs immediately without looking at the context of the question, you would have answered this question incorrectly. Remember, when we reworded this question stem, we asked ourselves, what is the highest priority for a fractured femur? So that would be immobilizing the affected limb with a splint. and asking them not to move. It does not mention anything about any sort of breathing issues there. So option 1 is the best answer. Here is another question where we are using nursing process as a test-taking strategy. A nurse is teaching a client with coronary artery disease about dietary measures to follow. During the session, the client expresses frustration in learning the dietary regimen. The nurse would initially, I'm going to underline the word initially, that is the key word in our question stem. So 1, identify the cause of the frustration. 2, continue with the dietary teaching. 3, notify the physician. And 4, tell the client that the diet needs to be followed. So you know that you can apply the nursing process here as a test-taking strategy because all of these options are either assessment or implementation. So remember, use the steps of the nursing process to help you answer the question. Did the nurse in the question stem do any assessment? Take a look at the question, and you'll see no, the nurse did not do any assessment of the client, and really she needs to figure out why there is so much frustration in learning the dietary regimen. What is causing that? So the only assessment action in these answer choices is 1, and that would be your correct answer, to identify the cause of frustration. All the other ones, 2, 3, and 4, are implementations. They are actions when we need to be assessing first, initially. So this brings us towards the end of our presentation here. We just have some review questions. What type of nursing intervention requires a healthcare provider's orders before they can be performed? So they require an order. So remember, if they require an order, it is a dependent nursing intervention. Which type of nursing care plan provides daily nursing interventions that change as the patient improves? Remember, we talked about how a critical pathway are types of nursing care plans that are similar to standardized care plans, but they are based on the progression for each day the patient is in the hospital. So I gave the example on a previous slide about post-op orders. Like day 1, I want the patient sitting up in the bedside chair. Day 2, the goal is to ambulate them in the hallway such and such amount of feet. So a critical pathway, is based on the progression for each day the patient is in the hospital.